All right, hi guys. A very good evening to all of you. Welcome back once again to our today's class of FARRE, which will be the second lecture for the day and second lecture in this series. And today we are going to quickly summarize all the high yield topics from autonomic nervous system. So what we have done again, we have analyzed multiple papers from the different universities from the top medical colleges of this country. And we have seen which all topics are very important from where most of the examiners are asking question. और अकॉर्डिंग टू द रिसेंट गाइडलाइंस रिसेंट सीवीएमई का जो पैटर्न है उसके अकॉर्डिंग कैसे पूछा जाता है हम उसको लेकर आए आप सभी के सामने. सो बिफोर आई स्टार्ट द सेशन टुडे प्लीज गिव मी क्विक कंफर्मेशन इफ आई एम क्लियरली ऑडिबल एंड विजिबल टू ऑल ऑफ यू गाइस. अगर सब कुछ ठीक है तो जल्दी से बता दीजिए. डॉक्टर संगीता चौधरी एंड ऑल माय डियर स्टूडेंट्स, ऑडियो वीडियो सब ठीक है क्या? आर वी ऑल अलाइंड दैट यस सर एवरीथिंग इज फाइन? सो अगेन जैसे कल मैंने बताया था कि रिसेंट सीवीएमई पैटर्न में एप्लीकेशन बेस्ड क्वेश्चन क्लिनिकल बेस्ड सिनारियो आपसे पूछा जाएगा. अब वो समय नहीं है कि दे विल बी आस्किंग राइट शॉर्ट नोट ऑन दिस, है ना, राइट डिस्क्राइब दिस पर्टिकुलर टॉपिक. तो पूरे एंटी हाइपरटेंसिव को एक साथ पूछ लेते थे. अभी वैसा नहीं है. अभी दे आर सपोज टू आस्क द क्लिनिकल बेस्ड सिनारियो. तो जैसे कि दो तरह के क्वेश्चन आपसे पूछे जाएंगे और तीसरा एक होता है एमसीक्यू बेस. तो एमसीक्यू बेस तो आप सभी को पता है कि जो भी एमसीक्यूज हमने यूट्यूब पे डिस्कस किए हैं आप हमारे नाम से सर्च कर लीजिए, या जो भी एमसीक्यूज हमारे पीडब्ल्यू मेडेट के ऐप में दिया हुआ है उन एमसीक्यूज को अगर आप सॉल्व करते हो तो आपका काम चल जाएगा. एट द सेम टाइम बहुत सारे एमसीक्यूज वी हैव ऑल्सो कवर्ड इन आवर निश्चय बैच आफ्टर द सेशन. हर छोटे छोटे टॉपिक के बाद चार पांच क्वेश्चन हम जो डिस्कस किए अगर आप सबको समराइज करोगे तो कम से कम 250-300 क्वेश्चन वो होते हैं. उसके बियॉन्ड अगेन क्वेश्चन ज़्यादा नहीं जाता है. ये हमारा एक्सपीरियंस है और अपने एक्सपीरियंस से बता रहे हैं, राइट. तो अगेन लॉन्ग आंसर क्वेश्चन में एक ऐसा क्वेश्चन है जिस तरह से ये मान लीजिए 10 मार्क्स का होगा, तो वैसे लॉन्ग आंसर क्वेश्चन दो हो सकते हैं. दिस इज एक्चुअली गोइंग टू बी अ 10 मार्क्स क्वेश्चन. सम टाइम ये 20 मार्क्स का भी हो सकता है एक ही क्वेश्चन, डिपेंडिंग ऑन college to college, examiner to examiner. So this is actually going to be a case of a 42-year-old farmer. He is brought to the emergency department semi-consciousness state after accidental exposure to an organophosphate pesticide. Okay, so they have already given the name of the pesticide. It's organophosphate while spraying his crops. He has profuse salivation, sweating, lacrimation. तो typical symptoms सारे हैं. pinpoint pupil bradycardia, bronchoria मतलब excessive bronchial secretion एंड मसल फैसिकुलेशन, डिफिकल्टी इन ब्रीदिंग. तो सारे सिम्टम दे दिया है, सेलिवेशन लैक्रिमेशन जितने भी हैं सब कुछ है. ऑन एग्जामिनेशन द क्लॉथ हैव अ कैरेक्टरिस्टिक पेस्टिसाइड ऑर्डर. तो बता भी रहा है ना कि भाई ऑर्गेनोफॉस्फेट है तो क्लॉथ का एक कैरेक्टरिस्टिक ऑर्डर है. मैं बता रहा हूँ ये टिपिकल लाइन है एग्जामिनर का. बायलैटरल डिफ्यूज क्रेपिटेशन. तो क्रेपिटेशन अगेन इज इंडिकेटिव ऑफ द सिक्रेशंस. एंड हियर they have given 4 different questions from the same part. So identify the most likely diagnosis. आई थिंक मुझे बताने की जरूरत भी नहीं है कि आपको पता चल गया डायग्नोसिस क्या, बिकॉज ऑर्गेनोफॉस्फेट स्प्रे कर रहा था, इतने सारे सिम्टम के साथ आ रहा था. बट एनीवेज एक्सप्लेन द मैकेनिज्म ऑफ टॉक्सिसिटी एंड एनलिस्ट द क्लिनिकल मैनिफेस्टेशन. कितने मार्क्स का है? 3 मार्क्स. सेकंड क्वेश्चन डिस्क्राइब द फार्माकोलॉजिकल बेसिस ऑफ एट्रोपिन थेरापी, मेंशन इट्स मैकेनिज्म ऑफ एक्शन. तो अगेन एट्रोपिन क्यों देंगे, एट्रोपिनाइजेशन क्या होता है, इंपॉर्टेंट साइड इफेक्ट क्या होता है, सारी बातें करेंगे. पार्ट 3 में एक्सप्लेन द रोल ऑफ प्राइडोक्सिन इन ऑर्गेनोफॉस्फेट पॉइजनिंग, इसके मैकेनिज्म के बारे में बताइए. एंड व्हाट इज द बायोकेमिकल फिनोमिनन ऑफ एजिंग ऑफ एसिटाइलकोलिनेस्टरेज एंड इट्स थेराप्यूटिक सिग्निफिकेंस क्या है, राइट. एजिंग से क्या होता है, उसका क्या थेराप्यूटिक सिग्निफिकेंस है. आउटलाइन द इमीडिएट मैनेजमेंट ऑफ द पेशेंट इंक्लूडिंग डीकॉन्टामिनेशन. इमीडिएटली क्या करेंगे, डीकॉन्टामिनेशन, एयरवे मैनेजमेंट, है ना, एप्रोप्रिएट यूज ऑफ एट्रोपिन. तो बेसिकली ये सारी बातें टोटल कितने मार्क्स की हो रही है? 10 मार्क्स की. तो वी विल मेक श्योर दैट वी आवर आंसर लेंथ शुड बी इन प्रोपोर्शन टू द साइज ऑफ द क्वेश्चन. सो अगेन डायग्नोसिस बताइए. तो ऑल ऑफ यू हैव ऑलरेडी सीन दिस वन. दिस इज एक्चुअली गोइंग टू बी अ केस ऑफ, दिस इज द केस ऑफ द above case is of organophosphate poisoning. organophosphate poisoning, organophosphate poisoning का केस है, ठीक है. एक्सप्लेन द मैकेनिज्म ऑफ द टॉक्सिसिटी. रिमेंबर ऑर्गेनोफॉस्फेट को हम शॉर्ट में लिखते हैं ओपी. सो ऑर्गेनोफॉस्फेट दैट वी नो, ऑर्गेनोफॉस्फेट ओपीज आर irreversible. Organophosphates are irreversible acetylcholine esterase inhibitor. Irreversible acetylcholine esterase inhibitor. So these organophosphates are irreversible acetylcholine esterase inhibitor. And what are they going to do? What are they going to do? These are actually going to inhibit right? They are actually going to inhibit acetylcholine metabolism. They are going to inhibit the breakdown or the metabolism of the acetylcholine. They are going to inhibit the acetylcholine metabolism, and therefore, because of this reason, because of this, there will be increase in the availability of acetylcholine. Acetylcholine का metabolism या acetylcholine का breakdown को क्या करेगा, ये inhibit कर देगा. So there will be excessive level of acetylcholine. Level of acetylcholine क्या हो जाएगा, बढ़ जाएगा, and therefore the patient को क्या क्या symptom आएंगे. Therefore your patient is going to present to you. The patients that we know are going to be with, patient is going to present with the all the cholinergic symptom. तो देखिए लाइन डायग्राम को बनाने में मैंने बिल्कुल भी देर नहीं किया है ना. लाइन डायग्राम हो गया या एरो बेस इंफॉर्मेशन हो गया, राइट. If you want to understand ANS from basic, I would strongly recommend that you try to watch out the Nischay batch lectures that we have covered, where I have started from the very basic, what actually is ANS, and what is the basic concept of nervous system, what is CNS, what is PNS, right? Everything has been discussed. In this lecture, if I go and talk about ANS, believe me, it will take another 2 hours just to talk about the basics only, right? So this is actually FARRE is mainly for helping the student, those who have read it already, and very basics have been discussed already in Nischay. Just watch the very first lecture and I can promise you everything will be sorted. ठीक है. अगर आप एग्जाम के समय में बेसिक की बात करेंगे तो वो थोड़ा सा आपके एंड से भी ठीक नहीं है, बिकॉज एग्जामिनर को पता है कि बच्चों को बेसिक तो आता है, एग्जामिनर मान के चल रहा है. ठीक है, चलिए. तो द पेशेंट विल हैव विद टाइप ऑफ सिम्टम, कोलिनर्जिक सिम्टम. पूछ रहा है एक्सप्लेन द मैकेनिज्म ऑफ द टॉक्सिटी, ये तो आपने बता दिया. एंड क्लिनिकल मैनिफेस्टेशन क्या होगा, तो पेशेंट इज गोइंग टू प्रेजेंट विद द कोलिनर्जिक सिम्टम. सो व्हाट आर द क्लिनिकल मैनिफेस्टेशन ऑफ दिस वन, राइट. So the next that I am going to discuss is going to be the clinical manifestation of this one. What will the clinical manifestation? So I think clinical manifestation we have covered it already. That clinical manifestation is going to be remembered by the simple mnemonic of SLUDGE, sludge at Facebook per, sludge at Facebook per या Facebook pin. So this is going to be the drugs. This is going to be the symptom like salivation, lacrimation, urination, right? Salivation, lacrimation, urination, diarrhea, GI distress, emesis. GI distress, why? Because of excessive acetylcholine will increase the GI motility. Then there will be fasciculation. Fasciculation का मतलब होता है fine tremor. Fasciculation का मतलब fine tremor, bradycardia, right? And pinpoint pupil. This pinpoint pupil is due to the excessive meiosis. Excessive meiosis is going to be pinpoint pupil, right? Excessive meiosis will be pinpoint pupil. Yes, right. We are using English only. Thank you for the reminder. Blessing hub. So we have the symptom that is going to be SLUDGE, sludge at Facebook, right? Facebook pin, sludge at Facebook pin. So these are the important clinical manifestations. So you see, this was the first question, and how many marks that they are asking? 3 marks. So I always say that never try to beat around the bush. Just be to the point. What is the examiner asking? Diagnosis. So you have given the diagnosis here: organophosphate poisoning. Explain the mechanism of toxicity. So this is going to be the second part: mechanism of toxicity, right? And the symptom. So 1 mark, 1 mark, 1 mark, 3 marks, right? Or if they are going to ask you half mark, that is 1 mark, and 2 marks on the symptom. That's it. That is done. Now the second part of the same question is going to be about describe the pharmacological basis of atropine therapy in this patient. Mention its mechanism of action, therapeutic endpoint of atropinization, and importance. So see, multiple sub parts are there. So if I would be examiner, I would never give 3 marks for this. Rather, I should give 6 marks. And this whole question is actually going to be of 20 marks. So it could be 10 marks or it could be 20 marks. Once again, I'm telling you, it depends on the examiner. It depends on the college. Same question, because we have lot of information that we are going to add on to this one. So this could be a part of 20 marks question as well, because the amount of information that they're asking in this very simple question here. So second part, describe the pharmacological basis of atropine therapy in the patient. So first part we'll be covering for this part B. All right. So since there is going to be too much cholinergic symptom, okay, remember atropine, they're asking what is the basis of atropine. Atropine is a non-selective, atropine is going to be a non-selective muscarinic antagonist, right? This will this agent or this drug atropine, this agent will reduce the cholinergic symptom. This agent is going to reduce the cholinergic symptom, right, in the patients, the cholinergic symptom in the patient, because atropine is one of the, it acts as M1 blocker, M2 blocker, and M3 blocker. Hashtag sign is for the blocker effect. M1 blocker, there will be decrease in the gastric secretion. There will be decrease in the gastric secretion. M2 blocker, M2 is mainly present on the heart. M2 blocker, they are mainly going to improve the heart rate. I am not saying that we want to cause tachycardia. We want to just improvise the heart rate because this patient was presenting with the bradycardia. So we are not waiting for the tachycardia, rather improvisation in the heart rate. So heart rate, if it was, let's say 45, 49, now we want to make it, let's say 65, 70, 70 and up. Take an improvement in the heart rate. And M3 antagonistic activity. So if it is going to pinpoint pupil, so I would say we want to make sure that there is improvement in the pupil size. Once again, I am not going to wait for the mydriasis. That's why I'm not writing that mydriasis, because again, M3 antagonist is called mydriasis. But in this patient, where there is already pinpoint pupil, you are not going to wait for the mydriasis, rather improvement in the pupil size. If it was pinpoint pupil, now the pupil size, let's say 3 mm, 2.5 mm, 3.5 mm, something like that. Okay, improvement in the pupil size. So starting from the eye, then they will also decrease bronchial secretion because the patient was also presenting with the bronchoria. So you have to talk around the patient. You have to be around the patient, right? Decrease the bronchial secretion, improvement in the pupil size, right? They will also decrease all the other secretions like oral secretion, other secretion. Okay. So improvement in the pupil size, all the patients are being targeted here through M3. M3 blockade will be, and they will also decrease the GI distress, decrease the other GI distress because of the M3 antagonistic property. So what is the pharmacological basis that I have told you? Mechanism of action here is also already mentioned. It's a non-selective muscarinic antagonist, right? And therapeutic endpoints. Therapeutic endpoint is going to be atropinization, right? So atropine that we are going to give here, atropine is going to be started, atropine in this patient will be started 2 milligram IV stat, and it should be repeated. You are advised to repeat every 10 to 15 minutes, right? This you will be repeating every 10 to 15 minutes, and remember it will be repeated till, this will be repeated till the atropinization. Now this is a very, very important term. What is the meaning of atropinization? Till the atropinization it will be repeated. What is the meaning of atropinization? Till we start to receive the atropine wala symptom, till we start to see the symptoms of the atropine. So what is the meaning of atropinization? Now we have to first see atropine is highly sensitive for the glands. So what are the atropinization? Till there is decrease in the secretion, till there is decrease in the secretion, again the same thing, decrease in the secretion, either bronchial secretion, oral secretion, all kind of secretion, till there is going to be improved heart rate, the patient present with the bradycardia, so improved heart rate, and till there is improved pupil size, improved pupil size. So we are going to give this drug till atropinization. This is a very, very important problem. Everything that I'm writing here, make just to make sure, if I want for some question, just to save some time, I have given pre-written as well, but I'm writing here and telling you because you have to be to the point. You, whatever examiner is asking, you have to write to the point. In earlier days, what we used to do, we used to just keep on writing. For a 5-mark question, we used to fill 3 marks, 3 paper, 3 page, 4 page, and at the end of everything, examiner will give you 3 marks, 3.5 marks. There is nothing else which is that could be written in that. Still examiner don't used to give the full mark. But nowadays that days are not there. In some places it is still there, but that sadistic approach that was there for the examiner, that for a 5-mark question you have written 4 to 5 pages, still examiner is giving 3.5 mark. Kyun bhai? बाकी 1 to 1.5 मार्क्स कहाँ चले गए? और अगर ये सर हर क्वेश्चन में करोगे, इफ यू कीप ऑन रिपीटिंग, इफ यू कीप ऑन रिड्यूसिंग 1.5 marks to 2 marks in every question, automatically the score will never be more than 60, 65, right? So if someone has written for 80 or 90, they should receive 80 or 90. I'm not saying everyone should receive, but if someone has written, they should receive. So in my paper, when I check, I make sure if it is to the point, if the student has written, they are supposed to get the mark. That's it. Okay. Welcome Saurav Chatterjee to the class, and all the other students as well. All right. So till the atropination, that is also there, and also they are asking important adverse effect. How many marks? 3 marks. So we can say, let's say 1 mark, 1 mark, and other one mark, right? So till the atropination, you will be repeating this one. The important adverse effect of atropine. The important adverse effect of atropine. The important adverse effect of atropine. This is actually the adverse effect of atropine. It is actually going to be the same, that there will be dryness of mouth, blurred vision, dryness of mouth, blurring of vision. It can even lead to urine retention. So again, multiple side effects are there, right? Urine retention. It can even lead to tachycardia, right? Dryness of mouth, blurring of vision, urine retention, tachycardia, right? All these important side effects. Dryness of mouth, blurring of vision, right? Tachycardia. All these important side effects are noted with atropine. In eyes, they can even lead to mydriasis. In eyes, they can even lead to mydriasis. So sometime in a patient with angle closure glaucoma, they can cause precipitation. So this is the third part. What we are doing, we are actually trying to understand the mindset of the examiner, and we are trying to figure out how will you describe the answer to the question. Then the third part of the same question, same case, that explain the role of pralidoxime in organophosphate poisoning, describe its mechanism of action, and its biochemical phenomenon of aging of acetylcholinesterase and its therapeutic significance. 2 marks. So lot of information. That's what I said. That if I would be one of the examiner, I would be giving 20 marks for this one case, right? So this should be at least 4 marks, because the number of information that they are asking this is too much. The role of pralidoxime, right? So in organophosphate poisoning, remember in OP poisoning, after the atropine therapy, right, oximes will be added. Oximes are supposed to be added. So you have to first write down what are the oximes. These oximes are going to be, let's say, pralidoxime, obidoxime. So again, they are going to be oxime, pralidoxime, obidoxime, and we also have diacetyl monooxime, that is going to be DAM. This pralidoxime is called PAM, DAM. This pralidoxime and obidoxime, they are effective peripherally only. PO, you can say peripherally only. So they act peripherally only. So if the patient is having CNS symptom, we'll be using the other one, that is diacetyl. Di means both, di means two. So this is going to act peripherally plus centrally both. Peripheral plus central both. So again, I have given some introductory part of what oxime. So they are asking a role of oxime in the organophosphate poisoning. So you can just write that oximes are the class of drug. Oximes are the new class of drug that are considered. Oximes are acetylcholinesterase reactivators. What are oximes? Are acetylcholinesterase reactivator. They are actually going to reactivate the acetylcholinesterase. They are going to what? Reactivate the acetylcholinesterase. They usually binds with, they are actually going to bind with the anionic site anionic site, I'll show you the image after some time, anionic site at the acetylcholine esterase enzyme and form a complex with oximes, form a complex with the oximes. So we can say phosphooxime complex, phosphooxime complex. So they will form a complex with the oximes, and after forming a complex, this complex is going to dissociate. This complex is going to dissociate from acetylcholine esterase enzyme. They are going to dissociate from acetylcholine esterase enzyme, leaving it again acetylcholine esterase again become reactivated. Always remember, whenever you are going to look at the structure of an acetylcholine esterase enzyme, so look at this, they are going to have two sides. Acetylcholine esterase are actually going to have two sides. One is called your anionic site and other one is called your esteric site. One is called your anionic site, other one is called your esteric site. Anionic and esteric site. So both the sides should be vacant. Both the sides should be vacant for the normal breakdown of acetylcholine enzyme. Acetylcholine, both the sides should be vacant. These acetylcholine esterase, it will have two sides, anionic, esteric site. Okay. So again, the question is saying describe its mechanism of action and explain the biochemical phenomenon of aging. Okay, so I think some slides have been taken downstairs here, right? I'll just tell you the other parts here on the next slide that we have. Now, oximes are mainly going to be effective. Oximes are effectively used before the aging of the enzyme, before the aging of the enzyme. So remember, if your esteric site is going to be occupied, let's say this is the site that is actually going to be occupied by the organophosphate. There are multiple organophosphate like parathione, malathione, diazinone, parathione, malathione, diazinone, chlorpyrifos, right? So they are going to cause this aging process. Aging means they will lead to irreversible damage to this enzyme. So before the aging only you have to give this one, and this aging time that we have, it varies from different organophosphate. Because we have multiple organophosphates, so someone is from 2 to 24 hours, someone will produce the aging in 2 hours, someone in 4 hours, someone in up to 24 hours. So you have to always give as soon as possible after, right, after the atropine. Therefore it is always and always added after this atropine therapy, after the atropine therapy, before this aging of the enzyme, because aging of the enzyme will take around 2 hours to 24 hours. It varies ki patient has taken which type of organophosphate. Okay, which type of organophosphate. So for 2 marks, this much information is good enough. And its therapeutic significance. So therapeutic significance is the same, that if you give it after aging, there is irreversible damage, and this acetylcholine esterase cannot be reactivated again. Outline the immediate management of the patient, including decontamination, airway, ventilatory. So immediate management, what will you do, right? So for the immediate management of this patient, for the immediate management of this patient, what you are actually going to do? First thing, including the decontamination, airway management. So how will you do the decontamination? Matlab, whatever the cloth the person is wearing, because remember, your patient, if you are listening to this lecture from the beginning, your patient presented and his cloth was having the odor. So you are going to do the decontamination first. Decontamination is the first step. That means you are going to remove the clothing which he has been wearing, because if you do not remove it and you are going to treat, there is a constant exposure, and that will create a competitive antagonistic activity with your drug. So first thing is remove the clothing, and you provide basic life support. Provide the basic life support, for example, your airway breathing. So that's what they are saying, initial stabilization that you are going to give. airway is clear, because again your patient is having too much secretion and you have started on atropine. That is why I mean you are starting on the atropine because of this reason only. You have to give the oxygen for the for the support, and you make sure the ventilation is normal, IV access, and monitor the vial. So immediately stabilize ABC, airway, breathing, circulation, right? This you have taken care. After that, after you have done, after you have managed the airway decontamination, that I have told you that you are going to remove the contaminated cloth, wash the exposed area thoroughly, and you're also going to do the gastric lavage. Sometimes the patient will drink the organophosphate because of suicidal tendency. So in that case scenario, gastric lavage may be necessary. But in this condition, because this is a farmer and he got exposed through the skin, gastric lavage may not be necessary. Gastric lavage is necessary if the patient had consumed, if patient has consumed the toxin orally. Okay. You also assess the erythrocyte cholinesterase activity. Erythrocyte cholinesterase activity. Acetylcholinesterase is the one that is actually inhibited. So a decrease indicates the acetylcholinesterase inhibition. And drug of choice, as I have told you, we are going to give atropine. So I think this is something that I have already covered. So this question is demanding this, so I'm writing it again. Immediate decontamination support, because it's only 2 marks, and appropriate use of atropine pyridoxine. So again the same question is being repeated. So airway, patient decontamination, measuring of the erythrocyte cholinesterase activity, and pharmacotherapy. You can start atropine followed by oximes. Oximes will only be effective in the organophosphate and not in the carbamate poisoning. It is repeated till the atropination. This also we have already covered. What is the meaning of atropination? Decreasing the secretion, improvement in the pupil size, improvement in the heart rate. Okay, oximes I have already covered. So there are two cases here. One is the case of, let's say, carbamate poisoning. One is the case of organophosphate poisoning. So what is actually happening in the organophosphate poisoning? These are just representative images. Okay, so we have, let's say, here is going to be your organophosphate, and carbamate is going to occupy combined both sides. Again, carbamate is going to combine what? Both the sides. Carbamate is going to combine both the sides. So this is actually going to be carbamate. This is actually going to be carbamate. Okay. So carbamate, what it is going to do, it will be acting on both the sides. Anionic and esteric side both. It is taking both the side, but organophosphate that we know, this is organophosphate, this is going to occupy only one side. So whenever we are going to give our drug, that is going to be oxime, what is oxime going to do? It is going to bind at one side by the name of, let's say, anionic side. This is oximes, and this will be forming a phosphooxime complex. This complex here is called phosphooxime complex, and they will dissociate from here. They are actually going to dissociate from here, right? Both the sides should be vacant. So this concept I have already discussed with all of you guys. Okay, so this was again a question where we have seen a lot of important information. So from past 28 to 30 minutes we are discussing this long answer type question, and I told you how you are going to tackle this kind of question. Sometime this will be again any part of this may be in a part of short answer as well, but the concept remains the same. What you are going to write, you can easily write from your Nishchay based lecture that we have. Okay, so this is second one. What is the basis of atropine therapy? What is atropinization? What is the side effect of atropine? Okay, then oximes, then we have the aging process, treatment, initial treatment, what will be done, right? Next, it is going to be the topic of short answer type question. SAQ. SAQs are going to be short answer type question. Short answer type question. SAQs. And the short answer type question will be usually 5 mark each. 5 marks each. Sometimes they give you 5 questions, 6 mark each. Sometimes they can give you 6 questions, 5 mark each. So I'm giving here 5 mark each, and there will be 6 questions, because this 6 question is going to be 6 high yield topics of your autonomic nervous system. So this is going to be again a case of 24-year-old woman develops sudden urticaria, wheezing. Now whenever you hear the term wheezing, that means something is going on with the bronchial constriction is happening, facial swelling and hypotension. The BP is quite low within a minutes of receiving an antibiotics. Okay, so here after giving antibiotic, the patient is having problem, right? And all the problem is representative of your anaphylactic, or I would say hypersensitivity reaction that is occurring due to the penicillin induced hypersensitivity reaction. Name the drug of choice and preferred route of administration. So first and foremost, this is actually going to be the diagnosis. Diagnosis is going to be anaphylactic or anaphylactic shock. Anaphylactic shock. BP is quite unrecordable. Anaphylactic shock due to penicillin, or I would say penicillin induced hypersensitivity reaction. That is an example of type B ADR. That is going to be very, very bizarre kind of ADR. It's going to be very, very bizarre, right? Bizarre kind of ADR. And what is the drug of choice? The drug of choice, because it's going to be only 1 mark, so you'll be just writing drug of choice and preferred route. So drug of choice is going to be adrenaline. Drug of choice is going to be what? Adrenaline. What is adrenaline? That is going to be sympathomimetic drug acting on the alpha and beta receptor. Adrenaline, we are going to give 1:1000. 1:1000, and out of this concentration we will be giving 0.5 milligram injected. The preferred is going to be intramuscular route, IM route. So just by writing this one, I think your 1 mark is done, because this is going to be 15 mark, 5 mark question. 1 mark is done here. Explain how its action on alpha 1, beta 1, beta 2 receptor reverse the major manifestation by anaphylaxis. So you have to now explain what all things are happening in the anaphylaxis that is going to be reversed by the adrenaline. Explain how its action on alpha and beta receptor reverse the major manifestation of anaphylaxis. Okay, so again, the action of these drugs on the receptors, like for example, they are going to act on the alpha receptors, they'll be acting also on the beta receptors, and they're also going to work on the beta 1, beta 2. Okay, so alpha 1 on the vascular smooth muscle, they are going to cause vasoconstriction. Because of that, the BP is going to improvise, the peripheral vascular resistance will increase and BP will increase, right? So this is again going to counter which problem? Because the patient was having marked fall in the blood pressure. That was the patient presented with the hypotension, right? So this will target, right? You have a patient with hypotension. You have a patient with hypotension. Beta 1, that will increase the heart rate, because your patient is having facial swelling and sudden urticaria, wheezing. Beta 1, they will improvise the heart rate, positive inotropic effect and positive chronotropic effect. Inotropic, chronotropic, right? They maintain the blood pressure in anaphylactic shock. And beta 2, they will be causing bronchodilation. So patient with hypertension, wheezing, so wheezing problem will also be sorted here, right? So here the wheezing problem will also be sorted. Plus inhibit the mediator release from the mast cell. So the vasodilatation, the swelling that was happening, that will also be, right, causes vasodilatation in the skeletal. Okay, no, causes the vasodilatation in the skeletal muscle beds, that improves the blood flow. And the swelling that will be local swelling, that may be countered due to the cutaneous alpha 1 receptors, right? So we have bronchodilation causing action, beta 1 that is causing inotropic, chronotropic, and alpha 1 is going to cause alpha 1 is going to increase the blood pressure, right? So adrenaline, it is going to counteract all the major feature of the anaphylactic, that is bronchospasm, hypotension, edema, and shock. So patient with the shock, edema, everything will be sorted here, right? So these are going to be name the drug of choice for the preferred. एक हो गया, this we are done. Explain how it is working. So alpha 1 is going to take care of the shock, beta 1 is going to take care of the problem like cardiac output, right? And beta 2 will be taking care of the wheezing, right? The bronchoconstriction. Now, why, the third question is, why intramuscular route preferred over subcutaneous in anaphylactic? So this is only 1 marks. This is only 1 mark. So you see here, you have given alpha 1, alpha 2, alpha 1, beta 2. So they are going to have 1 mark each. So 3 marks are done here. Why intramuscular route is preferred over subcutaneous? Because rapid relief, and you don't need more precision, because IV or subcutaneous will definitely take some time. IV, you need to find out the the IV access. This is very fast, and it provides the rapid relief and reliable absorption as well, especially into the deltoid and anterolateral thigh muscle. Subcutaneous, the problem is absorption is always slow. So we always discuss in the route of drug administration in general pharma that in emergency we never rely on the subcutaneous route. Emergency we never rely on the subcutaneous route. ठीक है. Intramuscular route, alpha 1 vasoconstriction, beta 1 cardiac stimulation, beta 2 bronchodilation and inhibiting the mediator release. So this was again going to be this is just a 1 mark question. So 1 mark is good enough. This much information is going to be good enough for this. So you have to see because writing answer in an examination is an art. I always say that knowing and writing are two different things. You know, you must be knowing that, but you should always know how to write it down, how to extrapolate that. This is the second short answer question. So I'll be giving you multiple short answer type question. So let's say this is going to be question number 1 short answer question. Total 30 mark short answer question I'll be giving, right? So 6 into 5, 30, right? So 6 question will be there. This is the second question. Essay key. During an experimental pharmacology demonstration, adrenaline initially produces a rise in the blood pressure after administration of the alpha adrenergic blocker. The same dose of adrenaline produces fall in the blood pressure. Okay, now this is going to be interesting. Here, what is the name of the phenomenon? So first, we have to understand, right? We have to understand first, this given scenario is actually going to be explained because you will be writing that adrenaline act on all the sympathetic receptors. Adrenaline act where? On all the sympathetic receptors like alpha 1, alpha 2, beta 1, beta 2, beta 3. But the action on the beta 3 is clinically not so relevant, so I'm not writing that deliberately. Now, out of these, remember, the predominant receptor throughout is actually going to be your alpha 1. That means if there are, let's say, 200 sympathetic receptors, so out of that I would say, let's say 100 are only alpha 1, right? 100 are only alpha 1. So whenever there is the initial exposure of adrenaline, someone which is very predominant or more in number, they will always take more amount of adrenaline because they're predominant, or I would say more in numbers, more in number. This is the basic concept, right? More in number. Third information that I would like to write is going to be about sensitive receptor. So something which is sensitive receptor, it is actually going to be beta 2. Beta 2 is going to be sensitive receptor. Beta 2 is going to be what? Sensitive receptor. That means at the lesser dose, right? Initial or high dose, it will always show alpha 1 as a predominant action. Alpha 1 will have predominant action. At low dose, beta 2 will have predominant action. At the low dose, beta 2 will have predominant action. At the low dose, beta 2 will have predominant action. So during an experimental pharmacology demonstration, adrenaline initially produces rise in the blood pressure. Since you have already understood this one, first I will tell you the concept and then I'll start writing the answer, right? So whenever I am going to give adrenaline to a patient, let's say this is going to be a blood pressure. Let's expose adrenaline to an experimental setup or in a patient in a condition where the blood pressure is, let's say, absolutely fine. Let's say this is going to be the 120 blood pressure, and at this point of time, if you have exposed your patient with adrenaline or epinephrine, there's the same thing. Which receptor will take more amount of epinephrine or adrenaline? Which one is more in number? Alpha 1. So because of the alpha 1 activity, adrenaline alpha 1 activity, this blood pressure will actually go up, the blood pressure will actually rise. Now this blood pressure will go from 120 to, let's say, 160, from 120 to 160. And when the level of adrenaline, it falls down into the body. Now at the lesser plasma concentration, tell me guys, which receptor will now be activated? So you will tell me, sir, now at this point of time, the beta 2 will actually be activated. This was alpha 1 mediated activity and beta 2 mediated activity. Now the blood pressure will further fall down because beta 2 will cause vasodilation. Once the drug is completely washed out, they will go back again to the normal. That is 120. So whenever we give epinephrine to the patient, always do remember epinephrine is an experimental setup. It will always have biphasic response or biphasic action. It is always going to have biphasic response or biphasic activity. This biphasic means two. Biphasic means dual response, two action. So this biphasic is going to be first increase in the blood pressure, then decrease in the blood pressure. First it will increase and then it will decrease, right? So epinephrine alone, whenever we are going to give, it will first increase and first decrease. But this, in this case scenario, what they're saying, that alpha blocker, if alpha blocker is given and this will be followed by adrenaline, then what is going to happen? Because of the alpha only, we saw the BP was increasing. Alpha blocker, let's say, is a drug that is given in a situation of hypertension. So if you're going to give alpha blocker because of the hypertension, let's say you have given the alpha blocker in the initial setup only, and because of that now the blood pressure is normalized. Let's say there was a hypertensive patient, because of the alpha blocker it is normalized. At this given point of time, if you are going to expose your patient with adrenaline, what you know already and what I have just taught you, that the BP should first increase and then decrease, and then after that it will go back to the normal. First increase, this is the normal one that you know, right? This is the normal one that you know. This is going to be biphasic response. But why this is not going to happen? Why this is not going to happen? Because alpha receptors are already blocked. Now because of this, the BP will try to go up but cannot go up. Why? Because alpha receptors are blocked. So adrenaline, all of them will now act on the beta. So this blood pressure, instead of going up, now it will actually go down, right? And there is going to be complete fall, or I would say further fall in the blood pressure. And once the drug is completely washed out, it will go back again to the normal. So when you are going to give the adrenaline in presence of alpha blocker, this particular phenomenon is called vasomotor reversal of Dale. What do we call them? Vasomotor reversal of Dale, or we also can call them Dale's reversal phenomena, or aka also known as Dale's reversal phenomena. Dale's reversal phenomena. Vasomotor reversal of Dale or Dale's reversal phenomena, right? So this is actually going to give only uniphasic response. So there will be uniphasic response, or there will be only fall in the blood pressure. Only fall in the blood pressure, which we call them uniphasic response. All right. So see, I didn't just give you the correct answer of A, I give you the entire concept here. So you know already, if the examiner is going to ask you, explain the vasomotor reversal of Dale. So you'll be writing the same thing, that adrenaline, if alone given biphasic response, because alpha 1 is more in number, beta 2 is more sensitive, beta 2 will respond always at the lesser dose. In presence of alpha blocker, the drug will be acting on the beta 2, and that will cause fall in the blood pressure. Okay. So explain the receptor and hemodynamic basis. So what they're asking here? After administration of the alpha adrenergic blocker, the same dose of adrenaline is producing fall in the blood pressure. I think you already know this one. The first question is done, vasomotor reversal of Dale, right? And second question, I think more or less I have given you the concept already. If you see here, normally adrenaline stimulates alpha 1 and beta 2. At low dose, alpha 1 will have more, because alpha 1 is always going to be right, alpha 1 is always going to be more in number, right? If a patient is pre-treated with the alpha blocker, example like let's say phentolamine, tolazorine, alpha 1 receptors are blocked, and now adrenaline can, right, alpha 1s are blocked, adrenaline can only act on the unopposed beta 2 receptors. So normally when we are going to give adrenaline, right, they are going to cause vasoconstriction normally. Okay. But after alpha blocker, if you are going to give adrenaline, so there will be only and only fall in the blood pressure. And there's the same graph that I have drawn here for all of you guys. You have to take care, you have to check this graph, right? So this graph you have to draw. This is the graph of vasomotor reversal of DL. This is a biphasic response. Normal upper wala is biphasic, and this is called vasomotor reversal of DL. So same concept we have explained already. Name a clinical condition where this concept is utilized for the therapy. So answer number C. So this concept of vasomotor reversal of DL, is mainly going to be utilized in the treatment of pheochromocytoma. Now what is the meaning of this? How do we utilize this pheochromocytoma? Pheochromocytoma, it is an adrenal medulla tumor. It is an adrenal medulla tumor, and we already know that this adrenal medulla, it will always secrete more amount of catecholamines. So they are going to secrete more amount of adrenaline, more and more amount of adrenaline. You already know, guys, that adrenaline is going to work on both the receptors. Adrenaline is going to work on both the receptors. They will be acting on the alpha receptors also and beta receptors also. Adrenaline is always going to work on both the receptor alpha and beta both. When it is going to work on the alpha, right, they will actually lead to vasoconstriction, increase in the peripheral vascular resistance, increase in the blood pressure. On the beta, if they are going to work, depending on whether they are working beta 1 and beta 2, or beta 1 if they are going to work, they can increase the heart rate, they can increase the force of contraction. If it is going to work on the beta 2, they will actually lead to fall in the blood pressure, right? Now, for the treatment of the pheochromocytoma, or I would say the drug of choice for pheochromocytoma, this is called pheochromocytoma, which I am writing as PCMA. The drug of choice for pheochromocytoma is actually going to be a drug by the name of phenoxybenzamine. What is the name of the drug? Phenoxybenzamine. Phenoxybenzamine, which is going to be an irreversible alpha blocker, non-selective alpha blocker, irreversible non-selective alpha blocker. So if you are going to block the alpha receptors, have you treated the patient? You may decrease the blood pressure, but the adrenaline is not going to stop because it is coming from this catecholamine or adrenaline is coming from the adrenal medulla. So this entire adrenaline will now be shifted towards the beta. Now they will continue to cause tachycardia, palpitation, right? So what you should add, the next question that was asked is that, what are you going to add here, right? So remember, along with this, with alpha blocker, with non-selective alpha blocker, you have to add a beta blocker. And this was also one of the questions in the very recent FMG examination, right? Even MCQ based question also can be derived from the same concept, that what you are going to add in this patient. So alpha blocker, right, along with alpha blocker, we will be adding beta blocker as well, because you have to block the beta. You have to make sure that you're blocking the beta as well. So add the beta blocker. Now, what is the order of the therapy? That was the question. What is the order of therapy? So always remember, you are going to give alpha blocker followed by the beta blocker. You are going to give alpha blocker followed by the beta blocker. That should be the order of therapy. It should not be other way around. And sometimes it is given option like give in any order. No, you don't give in any order. For example, let me just give you a scenario here. Just try to listen to me for one more minute, and then we'll be done with this question as well. Let's say you have not given any order. You have not given any order. You said, okay, you take it. Or you have said the nurse to give advice, but nurse did not provide the proper advice to the patient, right? Because when the patient was getting discharged, the nurse got a phone from her sister, है ना, दूसरे वार्ड से, दीदी का फ़ोन आ गया, हाँ दीदी जानती हैं दीदी, कैसे हो गया दीदी, ऐसे है मेरा पेशेंट, तो ऐसे है, मेरा डॉक्टर तो इतना बुरा है दीदी, डॉक्टर ने मुझे डांट लगा दिया दीदी। दीदी से बात करते 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 नर्स ने मान लीजिए कि पेशेंट को प्रॉपर एडवाइस देना नहीं समझा, और उस कंडीशन में पेशेंट मान लीजिए घर गया, एंड ही reached out to his medical right box, and he took out one of the medication. When he took out the medication, let's say in the carry bag, or I would say the paper bag of the medication that came out, it was beta blocker, and he consumed the beta blocker. I am just giving all a hypothetical scenario. Let us say he consumed a beta blocker, and after consuming the beta blocker, the adrenaline is still coming, and let's say hypothetical scenario once again that he got a phone call. The patient now got a phone call. from some of his old friend from college crush, and the college crush girl called him that, okay, hi Prakhar, yeah, hi, who we have, house, hi Saurav Chatterjee, and a long time no see, and do you know that you were my crush in my college day, but I could not say. Now this guy, and who is already in his 60s, talking to someone from his 20s, that someone was his crush, and he could not even approach, she could not approach. He kept on talking, oh no, that was, those were the golden days, I say, they kept on talking, kept on talking. And because he consumed alpha, beta blocker first, remember the adrenaline will now shift its entire activity towards the alpha. Adrenaline will shift will its entire activity towards the alpha, because again your beta is blocked, right? So the peripheral vascular resistance will increase further, that can increase the blood pressure. This could lead to multiple other complication. This can lead to condition like, let's say, ischemic stroke, or even, right, excess pressure can even lead to, rupture of the vessel, or many other complication, right? So because of this reason, you have to make sure, है, that you do not block the beta. Otherwise, if you give the beta blocker first, you might find the patient next day fainted on the floor, or maybe he is having some fatality, and people will only be able to see his phone details, that okay, he was talking to someone by the name of, let's say, Priya, and he's talking to, let's say, Priya or Shreya or whatever the name is, right? And people will understand, okay यार, कॉलेज की क्रश थी इसकी, है ना, श्रेया, और बात करते करते देखो कितना मोहब्बत था इसको उससे, बात करते करते चल बसा, बट एक्चुअली वो श्रेया से बात करते करते नहीं चल बसा, बिकॉज उसने बीटा ब्लॉकर खा लिया, इसलिए चल बसा. So you'll have to make sure that you advise the patient, you do not block the beta first, you give the alpha blocker first, followed by this you give the beta blocker. So order of therapy should be very, very clear, and this was the question that was asked in the recent FMG examination as well. What should be the order of therapy? So I think I have already made myself clear that the order of therapy should be alpha blocker followed by beta blocker. All right. So this was the third question. So you see, this much information is good enough for a question like this, which is for 5 marks, right? So this is one, this is going to be this, and this is going to be this, pheochromocytoma. Then another short answer type question. A 55-year-old hypertensive patient with a previous myocardial infarction started on a beta blocker. He also has history of bronchial asthma. All right, now this is going to be a very interesting question, and you guys, believe me, the type of topics that we have taken up for this, FARRE series, they are all very much important from the examination point of view. If any student is revising these topics and having a basic idea, they are going to get through this. I can totally guarantee you that. So a 55-year-old hypertensive patient with the previous MI is started on a beta blocker. He also has history of bronchial asthma. Classify the beta blockers on basis on beta 1 selectivity and additional vasodilating property with examples. So only 2 marks. So even if you give, let's say, 1 to 2 examples, that will be more than enough. So we'll be classifying the beta blockers into first generation, second generation, third generation. Explain their mechanism of action and major cardiovascular action. So again, mechanism of action and cardiovascular action, just 1 mark only. This could be more than 1 mark, I guess, but let's say that we are having 5 marks for each short question. Explain why non-selective beta blocker should be avoided in bronchial asthma and diabetes. So the third one is going to be very, very interesting, right? Third one is going to be very, very interesting, right? So whenever we are going to see the beta blocker, I can first start with the classification itself. The classification of the beta blocker, I can classify these beta blockers into first generation, second generation, and third generation. First generation, second generation, and third generation. The first generation beta blocker are going to be the non-selective beta blocker. This non-selective beta blocker, it is going to block beta 1 and beta 2 both. Second generation beta blocker are going to be the mainly beta 1 blocker, and therefore they are also given the name as a cardio-selective beta blocker. Cardio-selective beta blocker. Guys, be to the point. No need to write the story of movie Sholay, or no need to beat around the bush. Directly you can start right to the point. Third generation beta blocker is going to be beta blocker with additional, right, additional, बोला ना कि additional vasodilative property, So beta blocker with additional vasodilating property, these are all going to be third generation beta blocker. So we have 3 generations of beta blocker. So you just need to give 1 or 2 examples from the each. But if you can remember more, that is well and good, but you have to write only 1 to 2 1 to 2 example from each. The classification based on this one, beta 1 selective, non-selective, and with the additional vasodilating property, right? So we have atenolol, metoprolol, bisoprolol, esmolol, they are all going to be the cardio selective beta blocker. Propranolol, timolol, they are all going to be non-selective, right? Nadolol, sotalol. Then alpha blocking property, that is going to be your carvedilol, labetalol, that is going to have another additional property. So they are going to be beta blocker, but in addition to beta blocker, they have additional properties as well. Based on the vasodilating, we have nitric oxide release, that is nebivolol, and we also have something called your celiprolol, nebivolol, and another one is called celiprolol. Alpha 1 blocking property, carvedilol, labetalol, right? Alpha 1 blocking property, that is carvedilol, nebivolol. Then we also have something called your beta blocker with potassium channel opening property, that is going to be tilisilol. Potassium channel opening property is going to be tilisilol. So again, these are the beta blocker with the additional vasodilating property. So vessel can be it can be dilated using nitric oxide with the alpha 1. So alpha 1 carvedilol, lab beta, alpha beta, lab beta, alpha beta with the potassium channel opener. Okay. Then we have the beta blocker with beta 2 agonist, that is going to be your celiprolol. So they will have dual activity, bronchodilation, also vasodilating property as well. So there are different classes of the beta blocker that we have covered. Okay. Non-selective beta blocker, overall most commonly used is going to be propranolol. We have timolol, which is given in glaucoma, right? Sotalol is having dual property. So each beta blocker is having some important role. All the beta blocker, they are all going to end with the lol, which each one of you are already aware. Because you have to write down an essay based question, you cannot just read only lol, right? You cannot just read only lol. So beta 1 selective, there are multiple beta blocker, right? Some will say that A to N are all going to be the cardioselective beta blockers, A to N, but A to N will have multiple, right? So I say that you learn the beta 1 blocker will with the simple mnemonic of A2, B2, loves, celiprolol, metoprolol, esmolol, nebivolol. So these are the one, that is 9 cardioselective beta blocker. So we have 9, that is going to be SC-butolol, atinolol, see A2 okay. Then we have B2, that is going to be bisoprolol, bitaxolol eye drop is also available. Then we have a very short acting beta blocker by the name of landiolol. It is overall shortest acting. Lasting for around 4 to 5 minutes only, right? A2, B2 loves. C stand for celiprolol, that is having additional vasodilating and bronchodilating property as well. Then we have metoprolol, right? Esmolol, metoprolol, esmolol, and other one is called your nebivolol. Esmolol and nebivolol, right? So that is going to be your acebutolol, atenolol, A2, bisoprolol, bitaxolol, B2, loves, C, celiprolol, MEN, men, right? So because you have to write essay-based question, you have to know the names actually, right? So from here you can write few of them. The non-selective ones are very easy, like propranolol, timolol, for your twinkle eyes, timolol that is used in the glaucoma, right? Then what is the other part? So we have classified this one, that is going to be the 2 marks question. 1 mark question, explain their mechanism of action and major cardiovascular action. So they are competitive antagonists at the beta adrenoreceptors, that is going to decrease the heart rate, decrease the contractility, decrease the AV conduction. So decrease the heart rate, negative chronotropic, decrease contractility, negative inotropic, Decrease in the AV conduction, again dromotropic action. Okay, they will also decrease the renin release. Why? Because renin is mainly coming from the JG cell of the kidney. This is mainly coming due to the beta 1, because JG cell is mainly having beta 1 that will release the renin, and as soon as renin is released in the circulation, RAS system will get activated. So they will decrease the activation, or that is going to inhibit the RAS system activation. That is going to inhibit the RAS system activation. So because it is barely of how many marks? Let's say 1 mark. That much information is good enough. They are the competitive beta blocker, decreasing the heart rate, decreasing contractility, decreasing the AV conduction, inhibiting the RAS system activation. Okay. Third question from the same is going to be explain why non-selective beta blocker should be avoided in bronchial asthma and diabetes. This is going to be very conceptual question. See, whenever we are going to give your patient non-selective beta blocker, this is going to block beta 1 and beta 2. We are totally happy with the beta 1 because this beta 1 blockade will decrease the heart rate, will decrease the blood pressure, right? Decrease the force of contraction. So ultimately BP will also decrease. But beta 2 is normally present on the multiple side. Beta 2 at the respiratory system, if it is blocked, beta 2 at the respiratory system, if it is blocked, they are going to cause bronchoconstriction. Beta 2 causes normally what? Bronchodilation. Beta 2 at the blood vessel, they cause vasodilation, but when you block them, they'll be leading to vasoconstriction. Now there is beta 2 also on the liver. Whenever this beta 2 on the liver is going to get activated, this beta 2 on the liver normally causes gluconeogenesis, glycogenolysis. Because of this glycogenolysis, there will be increase in the level of glucose. There will be increase in the level of glucose, so they can lead to hyperglycemia. So whenever the body goes into hypoglycemic shock, whenever there is a hypoglycemia, let's say you are attending a class and class is getting extended and you are very hungry, a time comes when you say that okay, my hunger is subsided, I am not hungry anymore, मेरा भूख चला गया, मेरा भूख मर गया, ऐसे बोलते हैं ना कि our hunger is gone, I am not hungry anymore. So how your hunger is gone? Because your liver has activated its metabolic action of gluconeogenesis, and that has compensated for the requirement of the glucose. But when you block the beta 2 of the liver, now when you block the beta 2 of the liver, now there will be, they can lead to hypoglycemia, or I would say there will be no warning symptom of hypoglycemia. No warning symptom of hypoglycemia. In diabetes, and there is also going to be no reversal of hypoglycemia. There are two things that is going to happen. No reversal of hypoglycemia because you can easily understand. No reversal of hypoglycemia because you can easily understand this gluconeogenesis and glycogenolysis will not happen. Why the warning symptom will not take place? Because you have actually seen that whenever there is a patient with the diabetes, whenever there is a diabetic patient on oral hypoglycemic agent, one of the very, very important side effect that you can expect will always be hypoglycemia. This hypoglycemia will have symptoms like sweating, right? Tachycardia, palpitation, sweating, tachycardia, palpitation, tremors. All these symptoms are going to be seen. So there will be no warning symptom of the hypoglycemia except sweating. Sweating will be the only reliable symptom, right? Because we have beta 1 blockade, beta 2 blockade. So none of the other symptom will be seen because non-selective beta blocker will block everything, right? So there will be no tachycardia, palpitation, no tremors because on the skeletal muscle we have the beta 2. So in a diabetic patient, why we are not giving? Because it will lead to no warning symptom and no reversal of hypoglycemia. Why we are not giving it in asthmatic patient? Because they can cause bronchoconstriction. So again, we can write down the information in this case scenario here, because you have given here the basic information already. You can write down the information. Therefore, the non-selective beta blockers are going to be contraindicated in following condition. That is going to be PVD that I write. Sorry, BPD. Bronchial asthma and COPD. peripheral vascular disease like Raynaud's, and also in the diabetic mellitus, so they are going to be contraindicated in this, because in this one it can precipitate bronchial asthma, right here, because they're causing vasoconstriction, they can precipitate the Raynaud's. And diabetes may there will be no reversal of hypoglycemia, and there will be masking of hypoglycemic symptom, masking of warning symptom of hypoglycemia, there will be masking effect. Okay, so again, this was as I told you, this will be very conceptual. Even sometimes there are chances examiner can just ask you this one question in 5 marks, right? So the number distribution I have just given in a case-based scenario. So sometimes they can just ask you this one question in 5 marks series. They can just write in the detailed way, that one that I have given you here. 68-year-old hypertensive patient with the BPH is prescribed with alpha-1 adrenergic blocker. After his first dose, he developed severe postural dizziness. Identify the likely drug and its mechanism of action. 1 mark. So again, the drug that has been given here possibly, because in patients with benign prostatic BPH plus hypertension, the preferred drug that is given, because here they are saying alpha-1 blocker, the preferred drug which is given is called your alpha-1 blocker, selective alpha-1 blocker, by the name of drugs like your prazosin. Other drugs are also going to be drugs like your doxazosine, elfusosine, right, bunazosine, any of this drug ending with the zosine, right? Now these drugs are selective alpha-1 blocker. They can selectively cause vasodilation, and these drugs are mainly going to be associated with postural hypertension. They are going to be associated with what? Postural hypertension. Explain the pharmacological basis for its usefulness in both hypertension and BPH. So you have to write down again कैसे ये दोनों में effective है, BPH में भी effective है और hypertension में भी effective. So I think it's pretty obvious, right? It's pretty obvious that you know that in a patient with the benign prostatic hypertrophy, that alpha-1 blocker, it will decrease the peripheral vascular resistance, and this will decrease the blood pressure. Therefore this is going to be highly effective in hypertension. यही तो था इसका second part. This is the part B. How it is effective in hypertension BPH. Now what is actually happening, that alpha-1 blocker at all the sphincter, right, and other smooth muscle, right? So they will actually decrease the sphincteric tone of bladder, and they're also going to reduce the prostatic tone, because prostate also has alpha-1, right? That is also one of the smooth muscle, prostatic tone, and this is going to improve the urine outflow. This is actually going to improve the urine outflow, and because of this reason, these are going to be highly effective in BPH as well, because in patient with BPH there will be urine retention. Patient with BPH will have urine retention. Look at this. This is only for 2 marks. So this much information is very good enough for 2 marks. 1 marks each. Right? How it is effective on hypertension, how it is effective in BPH. We have given it here already. Third question from the same that we have. What is first dose phenomena? How it can be minimized? The first dose phenomena hota kya hai? What is first dose phenomena? So this first dose phenomena is mainly noted with vasodilators like alpha blocker, right, on the first few doses. ऐसा नहीं सिर्फ पहले ही डोज पे होगा, it is seen on the first few doses, right? This is mainly seen, right? This cause rapid, right? This cause rapid reduction in the blood pressure, rapid reduction in blood pressure, which we say postural hypotension, that is change in the position leading to fall in the blood pressure. This cause rapid reduction in the BP, right? Upon changing position, this mainly happened due to alpha 1 blockade, right? So there is the first dose hypertension. How to minimize? To minimize, start at low dose, and second thing, it is dosing is mainly done at night time, post meal, and at bedtime, at totally bedtime. Matlab, the patient has taken the meal, the patient has done his washroom activity, now he is on the bed, he will eat the medicine and he will go for the sleeping. That's it. उस समय पे दीजिए, so that he do not suddenly wake up. And you can also advise the patient to avoid the sudden standing from changing the position, right? Avoid सडन चेंज इन पोजिशन. फॉर एग्जाम्पल, आप उस पेशेंट को एडवाइस करिए कि जब आप बेड पर से उठें तो ट्राई टू सिट एटलीस्ट फॉर 1 to 2 minutes, पैर नीचे लटका करके, राइट, विद द लेग्स हैंगिंग डाउन द बेड. ट्राई टू सिट एटलीस्ट फॉर 1 to 2 minutes and then you slowly try to get up. Avoid sudden change in the position, right? So these are the way to minimize, right? So these type of question is definitely you will be finding this in your examination. So we had 6 questions. I think how many questions that I have covered? I think I have covered 4 if I'm not wrong. So this one was short answer question number 2. This one was short answer question number 3. And then there is going to be short answer question number 4. So we have 2 more questions that is left. 2 more left. I guess we'll be able to do that. Okay. So a 60-year-old patient with a primary open-angle glaucoma required long-term pharmacotherapy to reduce the intraocular pressure. Classify the drugs used in the glaucoma according to whether they decrease the aqueous humor production or increase its outflow. So 2 type of drugs will have: decreasing the production and increasing the outflow. Explain the mechanism of action of latanoprost and timolol. 2 drugs, 2 mechanism of action. Why should timolol be used cautiously in patient with the bronchial asthma? I think this question is easily answered. I have just told you. Timolol, it is a non-selective beta blocker. The third one I'll just answer here only. It's a non-selective beta blocker. They can precipitate bronchial asthma. Therefore avoided in such patients. Right. Another thing that you should know, that in bronchial asthma patient, in BA or bronchial asthma patients, what we are going to use, you are advised to use in bronchial asthma patients, use the selective beta 1 blocker, example betaxolol. This information I told you a while ago as well when I was classifying the beta blocker. So C answer is already answered here, and I have already covered this before as well, that why non-selective beta blocker is avoided in bronchial asthma, COPD, peripheral vascular disease and diabetes. Now A and B are left here. Classify the drugs using glaucoma, whether they are going to decrease the aqueous humor production and increasing the outflow. Right. So normally if you're going to see this, I'm going to give you a holistic approach on the glaucoma. Just sit back, relax, and 5 more minutes, and then glaucoma will be summarizing very beautifully. Normal intraocular pressure is going to be around 10 to 21 mmHg, and this is mainly going to be maintained due to the normal aqueous humor secretion, and whatever aqueous that is being secreted, there is drainage as well. So what is the site of aqueous humor production? That is going to be the pars plicata. Pars plicata is the anterior finger-like projection on the ciliary muscle, right? There is the ciliary muscle from where there is zonules that is holding the lens. This is called your pars plicata. This anterior portion which I am highlighting here is called your pars plicata. they are going to produce this aqueous humor at the rate of 2.2 microliter per minute. 2.2 microliter per minute. All right. Normal aqueous humor production. And then there is drainage. Whatever aqueous that is being produced, they are going to drain as well, which is dependent on the intraocular pressure. So drainage ke liye we have two pathways. 70% of the aqueous will be drained through the trabecular meshwork, which is a traditional pathway. Normally, majority of the aqueous will be drained via the trabecular meshwork, and 30% drainage is going to happen by the uveoscleral outflow. Right. So again, whatever the normal intraocular pressure that we have, it is dependent on the aqueous. Aqueous is one of the factor, right? So they are produced from the pars pelicata, 2.2 microliter per minute, and they are drained via traditional pathway, that is trabecular or uveoscleral pathway, right? Now, if the production is increased or the drainage is decreased, there will be increase in the intraocular pressure, right? So if I say for the open angle glaucoma, either there is going to be increase in the aqueous production और there is going to be decrease in the aqueous drainage. या तो production बढ़ गया है या drainage कम हो गया. So the aim of the therapy that we know, we have to aim it towards the two important things. One is decrease the aqueous production, and increase the aqueous ka drainage. Now, as I told you already, the aqueous drainage is mainly occurring by two. So we have to increase either the trabecular drainage, trabecular outflow, or we have to either drain the uveoscleral outflow. Now, normally, what is the traditional pathway? That is trabecular. Trabecular meshwork is actually blocked. Trabecular meshwork is actually blocked in the patient. Therefore, we mainly act on the alternative. The uveoscleral that was taking care of the 30%, now they have to be made, the major. So decreasing the aqueous production is going to be drugs like your alpha-2 agonist. Then we are having beta blocker, carbonic anhydrase inhibitor, and other one is called your dipivefrin, and which is a prodrug of epinephrine. So I always say, because you are only going to classify, and that classification is giving you 2 marks, you remember A, B, C, D, E, as simple as that. Decreasing the aqueous production is going to be A, B, C, D, E, right? A, B, C, D, E. Increasing the trabecular outflow, traditional pathway is going to be pilocarpine, that is going to cause meiosis. It is going to cause meiosis, right? And remember, epinephrine is also there, because epinephrine is having dual role, decreasing the production, also increasing the trabecular outflow as well. Uveoscleral outflow is mainly going to be by latanoprost, and also your alpha-2 agonist. Alpha-2 agonist like apraclonidine, brimonidine, right? Apraclonidine, brimonidine, these are the alpha-2 agonists. It is the only drug that is having this type of dual activity, decreasing the aqueous production and increasing the uveoscleral outflow. Beta blockers, drugs like your atenolol, but here, timolol, not atenolol, timolol, bitaxolol, carbonic anhydrase inhibitor like dorzolamide, dipivefrin, it's a prodrug of epinephrine. So if you are going to classify the drug here, look at the first question. Classify the drugs in glaucoma according to whether they decrease the formation or increase the outflow. Only 2 marks. So you see, you have already classified drugs decreasing the aqueous production, drugs increasing the aqueous drainage. That's it. We have classified. और अगर कहीं आपसे इसमें डिटेल में पूछ ले तो वी हैव डिटेल ऑल्सो अल्फा-2 एगोनिस्ट, अप्रैक्लोनिडीन, ब्रिमोनिडीन, कॉजिंग सीडेशन. हमारा आंसर यहाँ पे हो गया, बट ये डिटेल में हो गया. अप्रैक्लोनिडीन, ब्रिमोनिडीन, दैट इज हैविंग डुअल एक्शन, डिक्रीजिंग द प्रोडक्शन ऑफ एक्वस एंड इंक्रीजिंग द यूवेस्कुलर आउटफ्लो, कॉजिंग सीडेशन, एपनिया, लिड रिट्रैक्शन. बीटा ब्लॉकर, timolol, bitaxolol, right? They will cause NLD obstruction and precipitating of bronchial asthma, especially the non-selective ones. So we use the bitaxolol in history of asthma. Carbonic anhydrase inhibitor, as I told you, drugs like your dorzolamide, They are the carbonic anhydrase inhibitor. They will also decrease the production. Dipepinephrine, epinephrine, they will be utilized mainly in the secondary or uveitic glaucoma. Okay, they are not given in angle closure glaucoma. Remember, in angle closure glaucoma, they can cause mydriasis and they can precipitate. They also have dual action, decreasing the aqueous production and increasing the traditional pathway of trabecular outflow. Drugs increasing the aqueous outflow. I told you two type of aqueous outflow that we have. One is going to be uveoscleral outflow, and other one is going to be trabecular outflow. So I think trabecular also we have covered. Trabecular also we have covered. That is going to be pilocarpine. Pilocarpine, which is going to be an M3 agonist that is going to cause meiosis. And drug that is causing meiosis, they are going to increase the trabecular outflow. Uveoscleral outflow, latanoprost, bimatoprost, travoprost, tafluprost, they are all going to be prost. They are the most powerful anti-glaucoma drug, and their side effect is also going to be PGF2 alpha, PGFF alpha, which is going to be pigmentation of iris, growth of eyelashes, right? Foreign body sensation, and also they will lead to fat atrophy of the orbit leading to enophthalmos, because there is a fat atrophy of the orbit and acute uveitis. Alpha 2 agonists I have already told you, right? Alpha 2 agonists like apraclonidine and brimonidine. All right, so these are the important drugs that is going to increase the uveoscleral outflow. So I think we have covered here this question in much more detail than it is required. C, I have already answered. Explain the mechanism of action of latanoprost. So I think you already know latanoprost is a PGF2 alpha analog. PGF2 alpha analog, and timolol is a non-selective beta blocker. We have covered this all, right? This question is also covered. So you are going to answer like this only. So this was the question number 5th, if I'm not wrong. The last question that we have. The last question that we have here is going to be question number 6. Okay, here the last question is about a 30-year-old woman presenting with the ptosis, diplopia, muscle weakness. ANS chapter, and they don't ask question about organophosphate, they don't ask question about beta blockers, bronchial asthma, they don't ask question about myasthenia gravis. That's not possible. They will definitely ask, right? So this is the 6th SAQ. So 30-year-old women presenting with the ptosis, diplopia, muscle weakness, and worsens towards the which is worsening towards the evening. Acha, so diagnosis they have given. This is very kind of the examiner. Usually they do not give the diagnosis. You have to diagnose all by yourself. Explain the pharmacological basis for using anticholinesterases in myasthenia gravis. So diagnosis they have given here already. That's a very good news. Anticholinesterases. What is the meaning of anticholinesterase? That is going to be anti-acetylcholinesterase inhibitor that will increase the level of acetylcholine, like drugs like pyridostigmine, neostigmine. Compare the neostigmine and pyridostigmine. So we have to compare these two because it's 1 mark. So I think 2 differences, half mark each will be more than enough. And you are going to differentiate from myasthenia crisis, which is again a condition that is happening in myasthenia gravis, from the cholinergic crisis, which is mainly occurring due to excess exposure of the organophosphate. Mention the pharmacological approach to each, right? So pharmacological basis for acetylcholinesterase, remember, myasthenia gravis is a condition, is an autoimmune condition. Myasthenia gravis is an autoimmune. So सबसे first point you should write from here. It's an autoimmune condition where there is going to be autoantibody against post-synaptic acetylcholine receptor. If ever you get a chance, I always say try to draw the image. Never hesitate from drawing the image. This is going to be the acetylcholine, and on the post-synaptic acetylcholine receptor, you are having the autoantibodies. These are going to be the antibody AB. You are going to be the autoantibodies, right? You see these autoantibodies, they have occupied this site, and therefore they are not allowing the depolarization. They are not allowing the depolarization of the motor end plates or the postsynaptic receptors. Okay, they do not allow autoantibody against postsynaptic receptor that do not allow acetylcholine to produce the action or depolarize the motor end plate. Okay, so what is the pharmacological base of using acetylcholinesterase? You always know that at the synaptic left, what we have is going to be an enzyme that is called acetylcholinesterase. We know that we have an enzyme that is called acetylcholinesterase that is going to cause breakdown of acetylcholine into choline plus acetate, choline plus acetate. So if you are going to inhibit the acetylcholinesterase, the availability of acetylcholine at the synaptic cleft will increase, and this availability of acetylcholine at the synaptic cleft will make sure the availability of acetylcholine at the synaptic cleft will make sure that they will compete with the autoantibody, right? So whenever we are going to give any acetylcholine esterase inhibitor, they are going to increase the level of acetylcholine, and these are going to compete with the autoantibody. These are going to compete with what? Autoantibody. ठीक, इतना इंफॉर्मेशन इफ यू हैव रिटन, एग्जामिनर अगेन आपकी कॉपी को चूम लेगा, कौन है ये लड़का, है ना? Basis of using acetylcholinesterase. So again, this is the same thing. Anticholinesterase inhibit acetylcholinesterase, increasing the acetylcholine at the synaptic cleft, better activation, improve neuromuscular transmission. So जो भी इंफॉर्मेशन था मैंने पहले वाले का यहाँ लिख दिया आपसे. सेकंड क्वेश्चन क्या है? Compare neostigmine and pyridostigmine. तो neostigmine, as I told you, that they are only for 1 marks. So 1 each will be more than enough. या 2 कर दीजिए, 2 each. So duration of action, neostigmine is shorter acting, pyridostigmine is a longer acting or intermediate to longer acting. So pyridostigmine is more preferred, right? In acute uses, we can use neostigmine, but long-term control you need pyridostigmine. Neostigmine, there is one thing that you should know: they are very rapid action, and pyridostigmine little slower but longer acting. Slower but longer acting. So always remember, pyridostigmine is going to be more preferred in myasthenia gravis maintenance therapy. Myasthenia gravis maintenance therapy. And the third part of the same, which is again a 5-mark question only, is going to be a difference between myasthenia crisis and cholinergic crisis. So this is going to be 2 marks, I guess. Myasthenia crisis and cholinergic crisis, that is 2 marks again, right? So myasthenia crisis is mainly going to be seen due to a patient with the myasthenia gravis inadequate treatment, and cholinergic crisis due to overdose of acetylcholinesterase inhibitor or organophosphate and carbamate poisoning. Organophosphate and carbamate poisoning, where the patient will have all the symptom of sludge, salivation, lacrimation, urination, diarrhea, GI distress, and a fasciculation pinpoint pupil. In myasthenia crisis, the feature of myasthenia gravis will be seen like more muscle weakness, more respiratory distress, and decreasing the reflexes. With respect to treatment, you are going to decrease the treatment of anticholinesterases, right? Steroids and ventilatory support if ever it is required, right? Myasthenia crisis. Sometimes you also require IV immunoglobulin or plasmapheresis. Here, because there is going to be already too much problem here, cholinergic crisis, too much acetylcholine, so you will inhibit or stop the drug that is being taken here, and you will be treating this patient by giving the atropine and supportive care, atropine, fluid therapy, and supportive care. Whatever symptom that is coming, you are going to treat it accordingly, right? So this was again the important autonomic nervous system, where we have covered the topics like myasthenia gravis, we have covered topics like pheochromocytoma, we have also covered alpha blocker, beta blocker, postural hypertension, glaucoma is a very important topic that we have covered here as well. And we have also covered BPH, that is also very, very important for all of you guys, and it is always very commonly asked. Okay, BPH and postural hypertension, very commonly asked. We have covered this beta blocker that I told you already, and beta blocker classification. This is the concept of organophosphate poisoning, pheochromocytoma. All these have been covered for all of you guys. So we have given a very detailed coverage of autonomic nervous system, and if any student is going to revise their autonomic nervous system, at least these many topics, believe me, you guys are going to crack most of the question of autonomic nervous system. However, I would always recommend that try to solve the previous paper, but looking at the recent pattern question and the way NMC is giving training to their faculties, that how, what type of question they're going to make, what should be the language of the question, CBME pattern ke according, these are the type of question that they will be framing for all of you guys, right? So I hope all of you guys have enjoyed and quickly revise autonomic nervous system. और पुराने पैटर्न क्वेश्चंस आपको सॉल्व करने हैं तो आप फर्रे के पुराने सीरीज भी देख सकते हैं, फर्रे 1 फर्रे 2 के पुराने सीरीज हैं, कुछ क्वेश्चंस उसके इसके साथ कॉमन है, बट मोस्ट ऑफ द क्वेश्चन हियर आर गोइंग टू बी न्यूली फ्रेम्ड. सो आई विल सी यू इन माय अपकमिंग क्लास. सो आने वाले क्लासेस हमारे CNS और कार्डियो के होंगे, एंड we'll try to solve most of the high yield topics of those topics in the same pattern that we are doing here. ठीक है. Thank you very much to all of you guys. Enjoy your evening.